Welcome to this introductory lecture on integrative psychiatry. In this lecture, I would like to provide a broad overview of the specialty of integrative psychiatry and how it may be a solution to several issues faced in psychiatry today, especially in the context of the conventional approach to psychiatric illness. We'll review the problems faced in psychiatry today, a brief description of the integrative psychiatry conceptual model, several systems considered in the integrative psychiatry approach, and how these systems are considered as part of the holistic plan of care. According to the CDC, it is estimated that 1 in 5 adults and adolescents live with mental illness. By 2030, it is predicted that psychiatric illness, especially depression, will be the leading cause of worldwide morbidity and mortality. In the context of significant heterogeneity and symptomatic overlap in the categorical approach to psychiatric illness proposed by proponents of the DSM, misdiagnosis and disagreement upon diagnoses are common. This is a primary reason why the National Institute of Health has stopped funding DSM diagnosis-driven research initiatives and has urged revision of our current model. Treatment resistance is as high as 60% depending on the individual disorder. In the face of this, 2 out of 5 psychiatric professionals have experienced professional burnout, and many new professionals do not feel prepared for practice after graduating from degree programs. We need a new model, and with it, a new approach to patient care. The superordinate focus in conventional psychiatry is on above-the-neck experiences and symptomatic-oriented treatment. Much like other medical specialties, this approach is siloed and approached in a somewhat detached fashion with minimal consideration for how other systems interact with the brain and contribute to these experiences. We collect data on signs and symptoms and then contextualize these findings based on our theoretical model, which drives the way we understand the disease triad: syndrome, pathophysiology, and etiology. As an example, our patient tells us that they're experiencing depression. Based on our DSM-oriented model, we hone in on which DSM construct fits this experience with some inquiry and perhaps a PHQ-9 questionnaire, among other screening tools based on the DSM. We may conclude that yes, this appears to be consistent with the DSM diagnosis, major depressive disorder. While this syndromic-focused construct sounds good, a problem arises in the consideration of the other 2 elements of the disease triad: pathophysiology and etiology. In terms of pathophysiology, we of course focus on the brain. Neuroscience is a constantly evolving field, and we continually identify new region-specific abnormalities and associated implications. However, from a macroscopic scale, the astute clinician recognizes that it's the communication between brain regions that accounts for the expression of syndromes such as depression, rather than a reductive focus on specific brain region anomalies. We have also not quite made it to the level of designing therapeutic interventions that target isolated brain regions. Rather, they target networks. Going a step deeper, our etiologic focus in the conventional approach is on neurotransmission, the chemical communicators of the brain. This makes sense as the microcosm reflects the macrocosm, but perhaps at the expense of not considering the impact of other variables on neurotransmission, such as micronutrient and vitamin cofactors, amino acids, inflammation, endocrine interactions, hormonal interactions, and metabolic functioning, among other things. Psychiatry has become very focused especially on this particular region between neurons that has everything to do with communication on a microscopic scale, the synapse. Most psychotropics modify the communication actions of neurotransmitters, especially our big 3, serotonin, dopamine, and norepinephrine. These other variables significantly influence our consideration of pathophysiology and etiology. Questions such as how are these neurotransmitters synthesized in the first place? What ingredients are required? What systems influence this? Are paramount in uncovering root causes. Several biochemical steps lead up to the synthesis of neurotransmitters, and several body systems interact dynamically with these biochemical steps, ultimately influencing neuronal communication, which translates to the macroscopic level of neural integration. This carries us further into the etiology of illness and becomes the focal point of integrative psychiatry. While the conventional approach does not sound unreasonable, and has in fact helped several individuals experiencing psychiatric illness, it does not account for the whole picture, and there are several individuals for whom this approach is ineffective. We've already discussed the high occurrence of treatment resistance, depending on the condition, but what about individual treatment options? I like to look at the number needed to treat as a gauge of how effective a treatment option is. Duloxetine, for example, is one option that has a number needed to treat of 9. This means that 9 individuals need to be given duloxetine in order for 1 to benefit. Another good statistical measure of the effectiveness of treatment modalities is the effect size. For several treatment options, the effect size hovers around 0.3, which is barely significant, especially considering that this level of effect size is not even noticeable from an experiential or clinical observation perspective. Moving a step further back, what drives our choice between one option versus another? Well, if you compare several clinical practice guidelines, the conventional gold standard for evidence-based treatment decisions, you'll find that several conditions such as major depressive disorder, social anxiety disorder, generalized anxiety disorder, panic disorder, obsessive-compulsive disorder, PTSD, and several others, serotonergic agents are the frontline treatment. These exemplify impersonal and imprecise care. As we know in the clinical setting, there is much heterogeneity in terms of experience expression and response to treatment. To frame this, I'm reminded of Chris Argyris and his ladder of inference. This model describes how data is selected from our environment, i.e. reality. After the selection of data, it is interpreted. After interpretation, it is molded into an assumption. From these assumptions, we draw conclusions. From these conclusions, we establish beliefs. These beliefs then inform action. Chris Argyris also describes an effect referred to as a reflexive loop, whereby the establishment of beliefs consequently filters one's selection of data from the environment. In this way, beliefs shape reality. This effect highlights the importance of inquiry regarding the fit and feasibility of our beliefs or models. The astute clinician will bear this in mind when approaching patient care models, including formulative approaches. For a great and brief book on mental models, I recommend Shadow of the Neanderthal. Integrative psychiatry is a whole-person exploration aimed at transcending symptom-focused care and conventional diagnostic labels to analyze the root cause of symptoms. With the skill set of integrative psychiatry, the practitioner and patient collaborate on advanced analysis of the dynamic interactions between the brain and body, and between the body and the exposome, the sum total of environmental exposures. Based on this analysis, a personalized plan of care can be constructed for the individual using an integration of conventional pharmacologic treatments, psychotherapy, lifestyle modification, nutraceuticals, including herbals and botanicals, and spiritual interventions to assist in the actualization of wellness. In this model, we consider the interaction between above-the-neck and below-the-neck systems as well as the internal and external exposome, or environment. Let's take a closer look at some of these interactions in more detail. If we take the aspect of communication one step further, you'll see that what goes on at a biochemical level in the postsynaptic neuron following psychotropic administration is an interaction with the turning on, acetylation, and turning off, methylation of genes. This is epigenetics. Although the Human Genome Project failed to set the stage for identifying the genetic basis of disease, epigenetics has gained a lot of traction. In fact, this very event makes up part of the explanation as to why it takes 2 to 4 weeks for a psychotropic to build up a therapeutic effect. Another growing trend here is captured in the top left molecule, LMF or L-methylfolate. This is the proposed treatment for methylene tetrahydrofolate reductase single nucleotide polymorphism, now commonly measured on psychogenetic testing. This genetic anomaly and its associated protein is associated with methylation. However, as captured in this image, methylation is much more involved than just this single MTHFR gene and its protein. In a series of interacting biochemical processes, methylation involves the donation of a methyl group to neurotransmitters, nucleic acids, xenobiotics, and phytochemicals, effectively modulating their activity. As you can see, the tetrahydrobiopterin, or BH4 cycle, is directly linked to monoaminergic synthesis and is contingent upon the function of the other 3 cycles. In green, I've highlighted areas along this entire pathway that are measurable using more advanced diagnostics that are part of the toolkit in integrative psychiatry. To add to this, methylation is one of 6 phase 2 detoxification pathways. All of the detoxification pathways, divided into phase 1 and phase 2, are interrelated, and a problem along one of these pathways typically lends itself to a problem in another. While the conventional approach has started incorporating diagnostic testing of the cytochrome P450 pathway as it relates to choosing among psychotropics, integrative psychiatry expands this view to include an examination of more of the phase 2 pathways, as well as the cofactors and genes influencing these pathways, so they can be targeted as part of the overall treatment plan. When detoxification systems are not functioning adequately, reactive oxygen species or free radical generation is the result. Oxidative stress is the result of free radical excess. When oxygen binds to a free radical, it becomes a superoxide free radical. This then moves through a series of processes depending on underlying genetic vulnerability, detoxification capacity, and the availability of cofactors, converting into hydrogen peroxide, hydroxyl, and peroxynitrite. Oxidative stress contributes to inflammation, as well as damage to mitochondria, DNA, proteins, and fat. In integrative psychiatry, one of the things we analyze is whether or not the individual is in a state of oxidative stress. Where along these processes is there a problem, and how can we best support the individual? In light of our understanding of the kynurenine pathway, we can see why inflammation is a problem in the context of psychiatric symptoms. Instead of converting into serotonin and melatonin, tryptophan is shunted under the influence of inflammation, as well as estrogen dominance and hypothalamic pituitary adrenal axis hyperactivity, into the kynurenine pathway, where it is converted into kynurenic and quinolinic acid, 2 molecules that interfere with NMDA receptors and glutamatergic activity, accelerate free radical generation, and cause detrimental effects such as neurotoxicity and reduced neuroplasticity and synaptogenesis. A good quick measure of inflammation can be done through the use of a high-sensitivity C-reactive protein, which, if elevated above 1, is suggestive of hyperactivity of this pathway. Coincidentally, if a high-sensitivity C-reactive protein is greater than 1, individuals are less responsive to SSRIs. Aside from inflammation, hypothalamic pituitary adrenal axis hyperactivity is also known to activate the kynurenine pathway. Aside from activating this pathway, HPA axis dysfunction can contribute to inflammation by accelerating the synthesis and release of pro-inflammatory cytokines, and also directly impacts brain regions. HPA axis analysis can show us how cortisol rises and falls throughout the day in relationship to other hormones in the steroidogenesis pathway, so that we can determine the type of abnormality and how to intervene. This is a place where nutraceutical treatments really shine, as several agents, especially adaptogenic botanicals, have demonstrated an ability to regulate the activity of cortisol and reduce stress-related symptoms. Conventional psychotropics, particularly SSRIs, have been shown to perhaps indirectly impact the HPA axis. But apart from steroids mimicking cortisol, there's not much available to help regulate the HPA axis. The gonadotropic hormones are also part of the steroidogenesis pathway. Estradiol stimulates mRNA for tryptophan hydroxylase. In the setting of low estradiol, there may be a reduction in serotonin production. On the other hand, if there's an excess of estrone, another metabolite of estrogen, there is activation of the kynurenine pathway. This will also result in a decrease in serotonin synthesis. Advanced HPG axis testing can provide a breakdown of metabolites to illuminate the balance of progesterone, testosterone, and estrogen, as well as determine if there's a need for toxic estrogen metabolite clearance, DHEA support, or progesterone or testosterone supplementation or support. A major source of free radical generation endogenously is the mitochondria, with some inherent leakage along the electron transport chain. While we tend to think of mitochondria as a powerhouse generating energy currency for all cellular activities, it can also morph into a battleship. When injured, mitochondria shift from a focus on oxidative phosphorylation into a focus on free radical generation and the recruitment of immunocytes. This contributes to widespread damage, steals from the availability of intracellular ATP, and is implicated in several chronic disease processes and aging. Among several forms of injury, the injury can even be psychological as the HPA axis and vagus nerve innervate the mitochondria. ATP is a ubiquitous co-transporter at all synapses and neurotransmitter receptor sites, so it would benefit us to take a closer look. Several cofactors and genes are implicated in mitochondrial functioning, and through specialized testing we can take a look also at how each step is operating and where any hang-ups are between the breakdown of macronutrients and the electron transport chain. Through this analysis, and paired with other testing, we can examine how to best support the individual's mitochondrial functioning and support the differentiation into healthy and highly functional mitochondria. A system that has a direct impact on this, as a master regulator, is the thyroid. Oftentimes, the thyroid is examined by checking a TSH with reflex T4. However, as shown in this pathway, this only accounts for part of the picture. TSH signals the thyroid to release T4, which is ultimately converted over into active T3 or inactive reverse T3. There are several factors influencing the overall function of this process, but without a full analysis of thyroid functioning, we tend to miss several individuals who have an underlying thyroid disease. The brain is also very susceptible to thyroid hormone, and oftentimes the conventional cutoffs are not adequate to support optimal neurological functioning. Therefore, in integrative psychiatry, we analyze these labs from the perspective of functional medicine, using cutoffs that are geared more toward optimizing health as opposed to identifying disease. Along the way, we've seen several places where certain micronutrients are required as cofactors in biochemical processes. One of the most effective places to look when there's an imbalance here is in the gut. I like to think of the gut as the second brain, as the activity of the enteric nervous system mimics that of the central nervous system in several ways. Not only does it synthesize the same neurotransmitters, and in fact, arguably most of the body's serotonin, the junctions between enterocytes mimics what we see in the blood-brain barrier. There is also bidirectional communication between the brain and gut via the vagus nerve, and dynamic interactions with the endocrine and immune system. Comprehensive GI testing allows us to identify pathogenic and opportunistic organisms, dysbiotic patterns, commensal diversity, digestive and absorption functioning, and intestinal permeability, among other things. One of the strongest interventions in integrative psychiatry is the use of an organized approach to treat the gut, which oftentimes translates to psychological, symptomatic improvement as well. Metabolic dysfunction is another important consideration. In the context of hyperinsulinemia and insulin resistance, there's an impairment in MAO-A, MAO-B, NMDA, and AMPA receptors, as well as mitochondrial functioning. The net effect of this is an increase in oxidative stress, reduced monoaminergic signaling, impaired synaptic plasticity, and accelerated cellular death. Using advanced genetic testing and a functional approach to metabolic health, instead of identifying insulin resistance when it's too late, we can identify this early and start considering interventions to prevent metabolic syndrome and promote well-being. With all these considerations in mind, integrative psychiatry provides us with a toolkit to bring more objectivity into psychiatry and to consider the dynamic interplay between systems. Functional laboratory analysis teaches us to look at specific patterns in labs for cutoffs that are more relevant for optimization as compared to standard laboratory cutoffs that aim to identify the presence or absence of a specific condition. Several standard laboratory tests can be analyzed in light of a functional analysis to support the direction of the plan of care. Advanced testing is often incorporated to take a deeper dive into certain areas depending on the individual's phenotypic expression of illness. Testing guides us into an identification of the root causes of illness. This work also provides us with an idea of how the individual is responding internally to the external environment, allowing us to more effectively guide lifestyle and behavioral modifications to promote wellness. We understand that there is also an interplay between the internal and external systems. An analysis of internal systems provides a reflection of this interplay. Here, the integrative psychiatry specialist conducts a thorough analysis of the exposome and how a person is interacting with the external environment in order to consider lifestyle-oriented interventions. These interventions are tailored to the individual based on our understanding of how the internal exposome is responding to the external exposome. Consistent with what you see in clinical practice, if you take a medication or nutraceutical, but there's an antagonistic exposomic element interfering with the capacity to heal, then the treatment will likely be ineffective, especially in the long term. Several domains that become a focus for lifestyle modification in integrative psychiatry include relationships, nutrition, exercise, sleep, substance use and addiction, and spirituality. Lifestyle modification is much more complex than providing a list of recommendations for an individual to incorporate into their daily routine. Many can empathize with how ineffective this can be. However, with the incorporation of axiology, the study of values, and specialized techniques to analyze behavior and strengthen the links between actions and values, we can nurture behavioral transformation. You can probably empathize with how much easier it is to make a change when it's in line with who and what's important to you. This is all done within a frame, which becomes a means of spiritual intervention and a way to work on the level of personality. All of these considerations speak to the complexity of human experiences. To effectively navigate this, we need a guiding model. Using the theoretical model I've developed, we can hope to capture critical aspects of human experiences, identify the relationships among these aspects, and develop a personalized plan of care that nurtures health and well-being. The Center for Integrative Psychiatry is organized around these core domains: brain, behavior, body, balance, and beyond, to develop the clinician's capacity to analyze and treat each area effectively using the expanded toolkit of integrative psychiatry. This model nurtures an expanded understanding of the individual. By looking beyond above-the-neck or syndromic presentations and considering an expanded analysis of the internal and external environments to reveal the root causes of illness, we can collaborate with our patients to develop a personalized and precise plan of care. Without considering the whole person, we cannot hope to optimize mental and physical wellness. Minimize the burden of psychiatric illness by elevating your professional skills and targeting the root causes of illness through the Center for Integrative Psychiatry. Stop sorting through the leaves and get to the root. Thank you for listening.